Our next section will be reviewing the lateral structures of the knee. This includes the iliotibial band and bursa, the lateral meniscus and the tibiofemoral joint space, the popliteus tendon and muscle, and the fibular collateral ligament, or LCL. Most of the lateral structures lie very superficial and are readily located with ultrasound. The structures can be evaluated with the patient supine or with the patient with the knee in 20 to 30 degrees of knee flexion. Some sonographers will prefer the patient side lying with the lateral side up, while others will prefer to evaluate some of these structures from the posterior lateral approach with the patient prone. It's the sonographer's preference. Let's review the anatomy. Let's start our evaluation of the lateral side knee again by looking anteriorly, rotating to the lateral aspect. We'll remove a layer and we'll come into the first structure we want to see, which is the iliotibial tract attaching down to Gerdy's tubercle. In this model, it's much larger than it actually is in real life. Just lateral to that is the lateral collateral ligament attaching at the fibula. We'll look at that in greater detail in a second. The lateral collateral ligament running all the way down to the fibula. We can look at that lateral collateral ligament as well dynamically. Watching how the ligament tightens with knee flexion, and how the ligament moves with the varus stress as well. Let's look at the structures in greater detail, starting with the iliotibial band. The iliotibial tract runs along the lateral aspect of the thigh, inserts into Gerdy's tubercle on the tibia. It's very superficial and often easily palpated and sometimes visible in athletic subjects. As it passes over the femur, a small bursa is located just underneath the surface. This is a common site of friction and bursopathy. Another bursa lies just under the ITB at its insertion into Gerdy's tubercle. Both these bursa, like many other bursa, are not readily visible unless pathology exists in adjacent structures. When we scan the ITB, it's easily located in the longitudinal plane just above the femur in a very superficial location. Follow it down in a coronal oblique scan to its insertion. Turning the probe 90 degrees allows excellent visualization in the short axis as well. Here's the probe position and the view of the ITB coming down, crossing over the femur where a small bursa exists, crossing over the lateral meniscus, and inserting down into Gerdy's tubercle. Small bursa will exist here as well. Looking at the insertion in greater detail at Gerdy's, we see lateral geniculate artery and the meniscus as well as the femur here. In position for a short axis view, as noted here, and the ITB very easily seen just above the vastus lateralis as well. Let's take a look at how to scan this area. The next structure we're looking at is the iliotibial band. We're going to start with the patient's side lying, lateral side up. I've placed the probe directly over Gerdy's tubercle, and we're going to look at the ITB in a longitudinal approach. We're going to follow the ITB up the thigh. Looking at the ITB here, we can point out its distal attachment into Gerdy's tubercle. And then just underneath is a small bursa, and we can see a small black amount right in this zone here. Just next to that, as we come up, is the lateral geniculate artery, and just below that is the lateral meniscus. We can then go up to the ITB, which is very superficial, follow the ITB up. It will run across the popliteus hiatus, and it will come all the way across and go over the aspect of the femur, where you'll see a small little bursa underneath and comes over. This is a common area of friction that can happen as people develop an ITB bursitis. We can also test this area to see the bursa move and see the ITB by having him bring his leg up directly and then have him bring his leg back and forth. The next structure we want to visualize is the lateral meniscus in the tibiofemoral joint space. Let's review that anatomy. We just saw a good part of it just before. The meniscus is important if we see a meniscal cyst to help us determine if there's pathology here. We can also evaluate the tibiofemoral joint line to look for degenerative processes such as arthritis. Here we see the lateral geniculate vessels, popliteus hiatus, and the lateral meniscus. The meniscus is a triangular shaped structure between. The popliteus hiatus always has a curved little approach here where popliteus attaches here and is very anisotropic. And the vessels are very prominent when you turn your Doppler on. Let's look at how to scan this area. The next structure to look at is going to be the lateral meniscus. We're going to start in the same approach we did with the iliotibial band with broad attachment into Gerdy's tubercle. We'll again see the small bursa that lies underneath the iliotibial band in this position. And if I bring the probe slightly back posteriorly, we'll start to see better the lateral geniculate artery, which will be easily seen when we turn the Doppler on here. And then as we come back even more posteriorly, we will get into the lateral meniscus, which is a triangular structure sitting between the two bones in this position. Let's now look at the popliteus tendon. The popliteus tendon will attach in the popliteus hiatus. It can be easily seen in the short axis plane while looking at it. We often need to correct for anisotropy in this area because of the steep angle it attaches on this. Iliotibial band coming above, popliteus tendon is anisotropic here, sitting next to the lateral meniscus. Posteriorly, we're looking here behind the knee where we see the popliteus muscle. Coming up, it will come to form a tendon right in this zone. We'll review this in greater detail when we look at the posterior aspect. And again, here's the tendon crossing the lateral meniscus, coming in this fashion. Again, we'll look at this as we scan this, and also as we look at the posterior aspect. Let's review this anatomy so we understand this a bit better. Let's take a closer look at the popliteus tendon and muscle. It's a very posterior tendon starting on the lateral aspect of the posterior tibia here. Just above it is the sciatic and tibial nerve. It'll run a sharp oblique course running to attach on the femur just underneath the fibula-collateral ligament, which is pictured here. Let's look at how to scan this area. The next structure we're going to look at is going to be the popliteus tendon. The popliteus tendon attaches at the popliteus hiatus. It starts just next to the lateral meniscus, which we saw earlier, and the popliteus hiatus right here. We'll then try to follow this popliteus tendon, which is anisotropic at its attachment because of the oblique nature of it. We will focus on following this tendon out as it comes back over the joint, running here, and then it will be difficult to follow, and we'll have to make a turn as it runs oblique, and we'll change our depth down, and we'll follow that muscle as it comes down right here, directly above the femur in the posterior aspect, and then we have the popliteal artery, which sits above it. sitting in this location. Note the probe position of the very deep oblique angle that we're looking at in this probe position. It's a very oblique angle that we use to follow that tendon up and around in this fashion. The last structures we want to visualize is the fibular collateral ligament. The fibular collateral ligament goes and originates just above the popliteus hiatus and inserts on the fibula. It runs in an oblique plane, making it challenging to view the entire ligament in one scan. At its insertion, it's wrapped around by the two heads of the biceps femoris, both the long and short heads. This can only be seen with advanced equipment and an experienced sonographer. This may create significant anisotropy at this site and should not be confused with tendinosis or tear. Let's review this anatomy that we're looking at here and discuss two methods we like to do to visualize it. I prefer to visualize it from the posterior approach, but it can also be visualized from the lateral approach. Let's review the sonoanatomy. The LCL coming in here. Note that it can't be visualized all in one view. Fibula is here, so its attachment into the fibula runs in this plane here. Because it's running obliquely, we lose part of its fibers here, and this is its origin here. Popliteal hiatus, lateral joint, genicular artery, as we saw before, tib fib joint. The LCL here focusing on its mid-substance with the femur here, fibula here, seeing the compact fibers overlying the joint. And this is its attachment part coming across further into the fibula area and looking again at its origin off the femur. Here's a probe position we like to use, and when looked at posteriorly, this probe position. Let's review how to scan this area. The next structure we're going to look at is going to be the lateral collateral ligament. We're going to look at it in the same way we looked at the lateral meniscus and the popliteus hiatus. I will again have the patient side lying, put the probe directly down, and I will look for our key landmarks of the popliteus hiatus and of the meniscus. Once I see this popliteus hiatus, I know I will look again for the LCL, which will come just above the popliteus. To best see it, I need to rotate the probe or pivot the probe in its most distal aspect to line up towards the fibula. And here we can see the LCL coming in and attaching. And then I will bring the probe slowly towards the fibular head, follow the lateral meniscus as it goes above the joint, and further down as it goes above, down all the way down to the fibular head. As we get closer to the fibula head, you'll notice a few things. One is you'll notice a structure just above the lateral collateral ligament, which is the biceps femoris, one head of it coming in as the LCL pierces the biceps femoris, and a smaller head below, and in between again the LCL. Let's look at how to scan this also from a posterior approach. Our next structure to see is the lateral collateral ligament again. We're going to look at it in a little different way. I prefer this way to the patient side lying. I like the patient prone, and I put the leg in a figure 4 position here to make the ligament taut. I will then easily palpate the fibular head. I will then place the probe down in a longitudinal way, about a third of the probe over the fibula, pointing towards the popliteus in this manner. Once I place the probe down, I will then look to see the LCL, which is a very small ligament going and attaching at the fibular head here. As I move it up, you can again see the LCL piercing the two heads of the biceps femoris tendons. One head here and another just below it in this spot. Again, that's the LCL piercing through the two heads of the bicep. I then focus on the LCL and follow it up as a thin ligament coming across, focusing on it, following it all the way up as we follow it up to its attachment again into the popliteus hiatus just above the superior rim right here. That will cover our a review of the lateral aspect of the knee. Our next section will be the posterior knee, which we'll cover shortly.